Hello, and welcome to the ACR Journals on Air podcast. I am your host, Vicky Shammigan. For some years, scientists have been sounding the alarm at the rates of systemic autoimmune diseases rising faster than can be explained by genetics alone, leading some to question whether environmental factors might be playing a role. The manuscript we'll discuss today is Systemic Autoimmune Rheumatic Disease Risk, Association with Long-Term Exposure to Fine Particulate Matter. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures can be found in our show notes from today. It's a real pleasure to be joined today by the senior author of this manuscript, Dr. Sasha Bernatsky. Dr. Bernatsky is a renowned rheumatologist, epidemiologist, and health services researcher whose work has transformed the understanding of autoimmune diseases and their long-term outcomes. The James McGill Professor of Medicine at McGill University and a senior scientist at the Center for Health Outcomes Research and Division of Clinical Epidemiology at the Research Institute of the McGill University Health Center, Dr. Bernatsky leads internationally recognized studies on systemic lupus erythematosus, rheumatoid arthritis, and the impacts of immunosuppressive therapies. She is also the principal investigator for the CAN-AIM study, the Canadian Network for Advanced Interdisciplinary Methods for Comparative Effectiveness Research, whose mandate is to enhance the validity and accuracy of research on the comparative effectiveness and safety of drugs. Dr. Bernatsky has more than 400 peer-reviewed publications and has received numerous awards, including the Mary Betty Stevens Award from the Lupus Foundation of America and the Arthritis Alliance of Canada Katie Practice Award. Dr. Bernatsky is widely respected for her leadership in large collaborative cohorts, her rigorous approach to population-based research, and her commitment to improving care, safety, and quality of life for patients living with chronic autoimmune conditions. Welcome to the show, Sasha.
Thank you.
Thank you so much for joining us today to discuss your work. I'm wondering if you can begin with some context. You have extensive experience studying the epidemiology of autoimmune diseases. What made you want to focus on the association of autoimmune disease with exposure to fine particulate matter?
Well, it was always interesting to me that though multiple genetic risk factors for something like lupus have been identified, the attributable risk due to those known genetic factors wasn't huge. And the biggest specific environmental factors linking systemic autoimmune diseases that had been identified up to recently tended to be things like respirable silica, which is really not a common exposure. Early in my career, I had done some work on case definitions for rheumatic diseases using population-wide Canadian administrative data, and that gave me the idea that I could start looking at air pollution and rheumatic disease risk. It made sense to me because air pollution is something we're all exposed to at different levels, so it seemed really important to tackle.
Before we go deeper into your work, can you explain for our listeners exactly what fine particulate matter is?
Sure. Air pollution is not just specks of dust suspended in the air. It's actually very complex. It's made up of both droplets and particulate matter of varying sizes. Fine particulate matter is one of the more interesting because it's been linked to so many health hazards. By definition, it's the particles in air pollution that are 2.5 microns in diameter or smaller. So they're 30 times smaller than the width of a human hair. So they're so small, they're invisible. And because they are so tiny, when they're inhaled, they can get really deep into your lungs and actually cross over into the bloodstream. There's some evidence that once they get into our bloodstream, they can stimulate systemic inflammation. So there's a good rationale for studying fine particulate matter, which is also called PM2.5, as a trigger for autoimmune disease.
And tell us about the study population you used for this research.
We studied administrative health data from the entire province of Quebec, in which over 9 million people reside. That's the second largest population of all the 10 provinces and 3 territories in Canada. It represents about a quarter of all Canadians. We looked at all adult Quebec residents without a systemic autoimmune rheumatic disease, and then we followed them up over time to see how many developed a new systemic autoimmune rheumatic disease.
And since this study was retrospective, how did you determine that, whether someone has a systemic autoimmune rheumatic disease?
We used physician billing and hospitalization diagnostic codes. So in Canada, we have universal health care when it comes to physician visits and hospitalizations. Almost all Canadians have provincial health insurance. There's some that have federal, but most it's provincial. So each province in Canada keeps administrative records regarding each time a person sees a doctor in the public health system. And there are diagnostic codes associated with each time a doctor submits a billing for that. So you can use those diagnostic codes to identify people with new onset systemic autoimmune rheumatic diseases like lupus, for example. There's also, like in each province, including Quebec, data on hospitalizations with diagnostic codes, so you can pick up incident cases that way too. So we looked at the combined outcomes of all systemic autoimmune rheumatic diseases together. That's systemic lupus, Sjogren's, dermatomyositis, and polymyositis, scleroderma, and undifferentiated connective tissue disease. And we also looked at the two most common of those, systemic lupus and Sjogren's, separately.
And then how did you measure particulate matter in this study?
Other environmental scientists have already compiled information on air pollution at postal codes. Postal codes are like zip codes all over Canada. So the environmental scientists have done this using satellite imagery, which has been analyzed along with surface pollution monitoring stations that are all over North America and other countries too. We looked at annual levels of fine particulate matter overall and the components of fine particulate matter at the residential 6-digit postal codes of all the individuals we were following.
And then is there controlling for other confounders that you need to do that would account for other factors that might contribute to somebody's environmental exposure? I'm guessing there are other environmental exposures other than just air pollution, right?
They are, and it's tricky sometimes to tease that out regarding potentially effect modifiers or confounders. The data we were using do have individual level data on age and sex. And we also used indicators of socioeconomic status, which would be a possible confounder. So that's an indicator of the regional financial determinants in the population. We also adjusted for regional variations in local health services and urban versus rural residents. And the models looked at fine particulate matter overall, but also at its components, which include black carbon, dust, ammonium, nitrate, organic matter, sulfur dioxide, and sea salt. So these are all correlated exposures. So to tease out the individual effects, some of the modeling used methods where you allow each component to increase in deciles, so you can determine the differential weights of the individual components of that fine particulate matter air pollution regarding risk.
Wow. I mean, that's pretty deep. I'm wondering how many people ultimately were included in the data set that you analyzed, and then how many of those ultimately ended up having a systemic autoimmune rheumatic disease?
So we studied over 7 million residents for an average of 14 years and identified over 55,000 new cases of systemic autoimmune rheumatic diseases. We did find associations between fine particulate matter and systemic autoimmune disease in all our models. There was the same trend when we looked at Sjogren's syndrome and systemic lupus separately, but with lower precision. When you consider the hazard across the entire population, some have estimated that about 1,300 new cases of SARD or systemic autoimmune rheumatic disease might be attributable to fine particulate matter air pollution in that province. And then a novel element of our findings was that the 7 chemical components of fine particulate matter, it was ammonium that seemed to have the most effect. And that was interesting because ammonium has been associated with other health outcomes like asthma and even interstitial lung disease. So ammonium sources include not only road traffic and industrial activities, but also agricultural activities and wildfires. So as vehicle and industrial emissions have become more regulated, these other sources of fine particulate matter, especially forest fires, are likely to be increasingly important.
That's really interesting because I think many of us would not even think about those potential exposures. There were some limitations to the data. You mentioned this in the manuscript, that people can be exposed to fine particulate matter in venues other than their residential zip code. So, for example, during their commute or perhaps through their workplace. Can you share your thoughts about those limitations and then the other limitations of this analysis?
So all those you mentioned are potentially important, although fine particulate matter variations are such that where people live versus where they work may not be so different. But I would also acknowledge that administrative database case definitions are not perfect. I think They probably do a pretty good job of identifying systemic autoimmune rheumatic diseases as a whole. But sometimes when you're trying to use administrative health data to differentiate between systemic lupus and related conditions like Sjogren's, there's bound to be some imperfections there.
I'm kind of fascinated by that because it almost suggests that it's not dose dependent then. It doesn't matter if you work outside or in an office, your risk is the same if you are exposed by being in that region.
You know what's really interesting is that air quality indoors, it's not just like stepping outside. There's air quality indoors that is potentially related to what's outside. There's definitely considerations about working outside, exercising outside that we would probably want to be thinking about. Maybe those exposures are more of the acute exposures and we were looking more like annual averages. But all of these things are things to consider for sure.
Where are you taking this work next? What is your study team working on now?
Well, we just finished working with Jeff Curtis and Gail Kerr and others funded by the Foundation for Advancing Science, Technology, Education, and Research, looking at systemic lupus and air pollution with U.S. administrative data. We also have a research program where we work with May Choi and Marvin Fritzer on autoantibodies and air pollution, and that's funded by the Canadian Institutes of Health Research, and we'll be looking at fine particulate matter specifically from forest fires in those analyses.
That's really exciting. I'm looking forward to hearing more about that work in the future. I wanted to take you on a little bit of a detour now and go a bit deeper into your own history. You've obviously been really successful in the epidemiology field, but I'm kind of curious, how did you get your start in rheumatology and in epidemiology specifically?
So Janet Pope was one of the first to introduce me to rheumatology as a medical resident. And I then went to Winnipeg, where I did rheumatology training and was motivated to consider research by Haniel Gabalawi, Christine Peshkin, Kim Owen. And as a trainee, I joined the Canadian Network for Improved Outcomes in Systemic Lupus, which had been founded by Paul Fortin. And through that, I met Anne Clark. And I moved to McGill to do my PhD in epidemiology with her. I joined her lupus clinic, which had been established by the great John Esdale. And Anne and Paul introduced me to the Systemic Lupus International Collaborating Clinics, or SLIC, where I met so many more wonderful collaborators like Roz Ramsey Goldman, David Eisenberg, Ellen Ginsler, and so many others. And in lupus research, starting off, you always need to band together. So that was just so great. And then early on with Deanne Lacaille, Antonio Avino, and Carol Hitchen, I developed an interest in using administrative health data for research. So things kind of came together that way.
I'm sure through your career, you've had your share of scientific heartbreak, rejection, failure. Do you have any tips on what keeps you going when times get tough?
Well, I guess perspective, and for me, my spiritual life is central. I try to depend on God for everything. I know God loves me no matter what, so I try to see personal and professional failure through that lens. You know, we can work hard, we do our best, but ultimately, I believe the outcome is up to God. And that's easy to say, but it's hard to keep in mind sometimes.
Yeah, for sure. You're now in a role where you spend a lot of time mentoring others, as well as guiding large-scale research studies through to completion. Do you have any tips on being a good mentor?
Well, mentorship looks a bit different from like if you have a medical student versus a postdoc or even a junior colleague. But no matter what kind of trainee I work with, I ask them at our first meeting where they come from, what their goals are. When it's a graduate student, I ask them to chart out the timeline of what tasks they need to finish to reach their goals, and I try to review that timeline with them regularly. I think, though, I've been so lucky to have amazing people to mentor, people like Evelyn Vinet and Jessica Whitfield and Ariel Mandel. They're such superstars. They really make mentoring easy.
Yeah, that's good. We've had a few of your mentees on this podcast, actually, I'm proud to say. This next question is going to sound a little odd, but as you know, sometimes these very large research studies can almost be characters in their own story. What tips do you have for chaperoning large studies from conception through to completion?
Well, I guess it would be good advice to ask the same kind of questions that I would ask if it was a new student. Try to set the stage, really understand where we're coming from, what do we want to accomplish. So maybe we can think of the research project the same way. And I would say, especially when we write that research grant, it's sometimes so detailed that we can almost lose sight of the main character at times. So keeping the big picture, especially in terms of impact on patients, to me, that's very important.
Yeah, I think that's really good advice. And I'm sure people listening to this podcast will be thankful for hearing that from you. What do you wish now, as a more senior researcher looking back, what do you wish you had known when you were starting out?
Well, there's that saying that everything we need to know we were taught in kindergarten. So sometimes it's just an appreciation of those basic values that we're missing when we first start out, like listening to the opinion of others, not pushing my own agenda too much. These are things I still have to remind myself. But I have good role models like Marie Hudson and Inez Colmegna here in Montreal, who are such good collaborators. So I'm inspired by them.
Yeah, and you've discussed a few of your mentors. I wondered if you're wanting to give shout outs to any specific personal heroes who've helped you along the way. I know a few of them have been on this podcast, and a few of them actually very clearly told me that I needed to invite you on this podcast. Which all of you could join.
So kind. Yeah, I've named some of them, but Claire Bombardier, Carter Thorne, Vivian Bykirk, Alan Rosenberg, who shared their love of rheumatology with me, and other research greats like Murray Urwitz, Daphne Gladman, John Hanley, Sue Manzi, Michelle Petrie, Askenazi, Joan Merrill, and so many others. I know I'm forgetting people. But also my own division of rheumatology at the McGill University Health Center. They're all heroes, and I just love working with them. And finally, I want to shout out to Miko Katsumoto, Tom Bush, Paul Dalla Ripa, Yasmin Ventura, Olivia Casey, Stephanie Tom, and others for their efforts to raise awareness of environmental factors in rheumatology. And you can find them at reactroom.org.
Yeah, no, I listened to that list of names and kind of wowed by the closeness of our community and how people really do help each other out.
Yes, absolutely. So grateful.
Yeah, it's really nice to hear you talk about them. Sasha, thank you for sharing your work with us today and the experiences and indeed exposures that have shaped your success. I really appreciate you coming on the show.
Thank you so much.
And today, in closing, my thanks go to epidemiologists, the remarkable scientists who devote their careers to studying things that are often invisible, complex, and incredibly hard to measure. By sifting through the patterns and data and uncertainty, they help the rest of us understand the world we live in, what keeps us healthy, what puts us at risk, and how environments and choices shape long-term health outcomes. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.